Hello. Today we are going to discuss a very common reason which is usually missed by our young consultants and young doctors while diagnosing a patient of chronic dyspepsia. That particular condition is biliary gastritis. And an interesting thing with this disease is that we are unable to diagnose it until unless we see duodenogastric reflux of bile on a endoscopy. The symptoms are the same. The patient presents with flatulence or abdominal distension or burning or pain in upper abdomen. And this disease is so resistant to treatment that mostly patients, they present with very chronic course and chronic history of this disease. How we diagnose this disease when we see the reflux, as I have already mentioned, of bile, and stomach is filled up with bile, and sometimes we see bile in the esophagus, and patient may present with GERD, symptoms of GERD in that particular condition. This is a very common condition in our part of the world, and we see patients who are either they had the surgery of gallbladder, they had cholecystectomy, and then they presented with this condition, or the patients, they are having this illness without having a history of surgery of gallbladder. Once we diagnose this disease, then the challenge is how can we treat it. And patients are in such a problematic condition that sometimes nothing helps. We try to make their life easier and comfortable, but it becomes very challenging. So the idea of making this clip is to make our consultants, make our doctors aware of this, the importance of putting this in the list of the etiology of chronic dyspepsia. When you see a case with this problem, always consider the patient can be having biliary gastritis. If your patient is not responding to your first line of treatment, even if you have eradicated and you have seen for H. pylori, and your patient is not responding, then send the patient for upper GI endoscopy and try to exclude the biliary gastritis. How do we treat this condition? The pharmacological treatment is very small options. We have got very small options. We've got biliary sequestrants with the name of cholestyramine. We give our patient cholestyramine with 4 gram cholestyramine twice a day, and patients, really there is availability issue and the cost issue. Patients, they have got this problem of getting this drug easily, and the response is very meager. Second option is we give UDCA, also deoxycholic acid, to the patient, and the response is not very good. We ask for the lifestyle changes to the patient. We ask for fat avoidance, for reducing weight, and to some extent even the patient responds. Sometimes acid reduction has got a role in the treatment. Then when the patients do not respond to any medical therapy, we have got the option of, theoretically speaking, of surgery. And in surgery, we advise for the bypass, for the diversion procedures, where the bile is avoided to drain in stomach and it is sent in intestine. So even then, the options are very little. There are very few surgeons who do this diversion surgery, and usually these patients, they end up in a diagnosis of IBS, but this is not IBS. This is biliary gastritis leading to chronic dyspepsia, and patients are having very long course, and patients are in very condition of great agony. So the message to my young consultants, to my young doctors is, whenever you see a case of chronic dyspepsia, always keep the possibility of biliary gastritis, especially in our part of the world, because this is a very common condition, and by negating this condition, we cannot cover the condition of chronic dyspepsia competently. Thank you very much, and take care of you. Allah Hafiz.